healthy heart pumps red, oxygen-rich blood, but when something goes wrong with the heart at birth, these babies can literally turn blue. Let's break down congenital heart defects. Oxygenated. Then it comes back through the left side of the heart and up and out the aorta to perfuse the body. So for congenital heart defects, blood flow is either depending where the defect is located, most of the blood leaving the heart is either oxygenated, like in acyanotic defects, or deoxygenated, like cyanotic defects. So the main problem with cyanotic defects is, you guessed it, cyanosis. So most of the blood leaving the heart is deoxygenated, or aka blue blood. Therefore, it causes these babies to get blue. So hypoxemia and cyanosis can kill babies fast. So cyanotic defects are more critical than acyanotic. A healthy heart pumps red, oxygen-rich blood, but when something goes wrong with the heart at birth, these babies can literally turn blue. Let's break down congenital heart defects for the NCLEX. So let's go over normal blood flow through the heart. So it goes through the right side of the heart to the pulmonary artery and out to the lungs where it's oxygenated. Then it comes back through the left side of the heart and up and out the aorta to perfuse the body. So for congenital heart defects, blood flow is either shunted, meaning going the wrong direction, obstructed, or mixes abnormally. So these are classified as either cyanotic or acyanotic. So depending where the defect is located, most of the blood leaving the heart is either oxygenated, like in acyanotic defects, or deoxygenated, like cyanotic defects. So the main problem with cyanotic defects is, you guessed it, cyanosis. So most of the blood leaving the heart is deoxygenated, or aka blue blood. Therefore, it causes these babies to get blue. So hypoxemia and cyanosis can kill babies fast. So cyanotic defects are more critical than acyanotic defects. So cyanotic defects are classified into defects that decrease pulmonary blood flow, like right to left shunts that bypass the lungs, like tetralogy of Fallot, and mixed blood flow defects, like transposition of the great arteries, that cause mixing of deoxygenated and oxygenated blood. So to remember this, most of the cyanotic defects begin with the letter T. So when you think T, think treble. These defects include tetralogy of Fallot, tricuspid atresia, transposition of the great arteries, truncus arteriosus, total anomalous pulmonary venous return, and one non-T defect, hypoplastic left heart syndrome. So we're going to focus on transposition of the great arteries and tetralogy of Fallot because they're super testable on the NCLEX, so pay attention. Tetralogy of Fallot has 4 defects, hence the name TET, which means 4. So pulmonary stenosis is when that pulmonary valve gets hard and stiff. Therefore, blood cannot easily go to the lungs, and instead, that blood builds up in that right ventricle. In the right ventricle, it builds up pressure and causes right ventricular hypertrophy. Then that blood has nowhere to go except through the hole in the ventricle, or ventricular septal defect, or VSD. So that shunted blood goes to the left side of the heart and goes up and out this overriding aorta, which is an aorta malpositioned over the ventricular septal defect. Therefore, most of the blood leaving the heart never made it to the lungs to get oxygenated. So in transposition of the great arteries, the aorta and pulmonary artery are completely switched. So there's 2 separate circuits of blood flow, one from the left side of the heart to the lungs and back, and one from the right side of the heart to the body and back. So how do these babies even survive? Well, they can't unless there's another defect present, like a patent ductus arteriosus or ventricular septal defect. Those defects allow just enough oxygenated red blood to mix with that deoxygenated blue blood and perfuse the body. So what do these babies look like? Well, remember, they are cyanotic, and sometimes they have these cyanotic spells or hypercyanotic spells called TET spells. This is when they are exerting themselves, like with crying or eating, and that can cause increased oxygen demand and cause them to become blue. Because feeding requires so much energy and oxygen demand, it causes them to be poor feeders, and therefore they even lose weight and have growth failure. Last is polycythemia. Because they have that hypoxemia, the body is trying to compensate by increasing red blood cell production. In order to do that, though, it causes that blood to get really thick and increase the risk for clotting and stroke. So for interventions, what do we do for these clients? These clients need surgery in the first few weeks to months of life to correct the defect. For transposition of the great arteries, we need to give prostaglandin E1. That will help keep that ductus arteriosus open to allow mixing of blood in order to ensure survival while we're waiting for surgery. Nursing care while we're waiting for surgery focuses on managing hypercyanotic episodes and maintaining fluid balance. So managing hypercyanotic spells, we need to increase oxygenation and lung perfusion. We can do this by comforting the infant or child. Remember, this spell was probably brought on by increased exertion from crying or eating, so we need to calm them down to decrease oxygen demand. So the NCLEX may ask you, how do you position a client during a TET spell? Well, we do it knees to chest. Remember, that increases pressure on the lower extremities, therefore increasing systemic vascular resistance. That increases pressure on that left side of the heart and causes shunting back to that right side of the heart and up through the lungs to be oxygenated. Then we give 100% oxygen and morphine as prescribed because those are pulmonary vasodilators that help increase blood flow to the lungs. Next, we need to maintain fluid balance. We offer small, frequent feedings, not large feedings, because remember, that increases oxygen demand. Then we monitor eyes and nose, like daily weights and weight diapers. Remember, we need to ensure that this client is hydrated and has adequate perfusion. We need to give IV fluids as needed in order to ensure perfusion and hydration. So remember, this client has polycythemia, so they're even at increased risk for stroke. So hydration is essential. So our first NCLEX quick check, what is the best position for a client during a TET spell? Well, remember, that's that knees to chest. We need to increase that systemic vascular resistance and therefore increase blood flow to the lungs to be oxygenated. So what should the nurse administer to clients with transposition of the great arteries? Well, we need to keep that ductus arteriosus open to allow the mixing of that blood. So we need to give prostaglandin E1 to do that. Now we have acyanotic defects where our main problem is heart failure. This is because fluid builds up within the heart and causes pressure on the ventricles and leads to strain on that heart and heart failure. These are classified by two main groups: defects that increase pulmonary blood flow, like left to right shunts, such as patent ductus arteriosus or septal defects, and we have obstructive defects, like coarctation of the aorta and pulmonary and aortic stenosis. So patent ductus arteriosus is an opening between the pulmonary artery and aorta that fails to close in the first few days of life. This is left over from fetal circulation. So this causes blood to go from the aorta to the pulmonary artery. So there is shunting from the left side of the heart to the right side of the heart. So for findings, remember this hallmark sign for the NCLEX, a continuous machinery-like murmur. Then we also see bounding pulses and a wide pulse pressure. Next, we have septal defects. Septal defects create an abnormal opening between the atrium, ASD, ventricles, VSD, or both, atrial ventricular septal defect. This is, again, where blood is shunting from that left side of the heart to the right side of the heart, where there's increased blood flow to those lungs. Then for findings, we see a heart murmur because of that abnormal opening. Now for obstructive defects, we see coarctation of the aorta, and that's when there's a narrow aorta that obstructs blood flow out of the heart. So think of this as a kinked garden hose. Close to the kink or defect, there is increased pressure. So we see bounding pulses and increased blood pressure in the upper extremities proximal to this defect. Then we see weak pulses and decreased blood pressure in the lower extremities distal from the defect. For aortic and pulmonic stenosis, there is narrowing or stiffening of the aortic and pulmonic valves, and that causes decreased cardiac output. So for findings, we see a heart murmur because blood is flowing through that narrowed valve. So what do these acyanotic clients look like? So for findings, because of these abnormal openings or stenotic valves, we see murmurs and abnormal pulses. We also see signs of heart failure, like dyspnea, fatigue, and sudden weight gain, just like we would in adults with heart failure. Then we also see signs of poor feeding because remember, they have dyspnea and fatigue, so they are not good at eating, and they have weight loss and growth failure. For interventions, we prepare for surgical and non-surgical repair as needed. Then for patent ductus arteriosus, we need to close that defect with indomethacin, a prostaglandin inhibitor. Before repair, nursing care needs to focus on maintaining fluid balance and improving cardiac output. So in order to maintain fluid balance, we need to monitor I's and O's because remember, perfusion and hydration is essential in these clients with congenital heart defects. Then we need to improve cardiac output. We do this by decreasing stimulation. We don't want to put any more strain on that heart, so we need to cluster care and give small, frequent feedings. Something like a large feeding can really strain that heart. Then we give heart failure medications, just like we would with adults with heart failure, diuretics, and digoxin. For digoxin specifically, we monitor for hypokalemia because that can increase risk for toxicity. Then we need to assess apical pulse for 1 minute before giving digoxin because it can cause serious bradycardia. Next NCLEX quick check, clients with congenital heart defects require frequent, large feedings or small feedings. Well, remember, we don't want to give a large feeding that can increase oxygen demand and exertion on that heart, so we want to give small, frequent feedings. What blood pressure finding is typical in coarctation of the aorta? Well, think of that kinked garden hose. Remember, the pressure builds proximal to that defect, so it's higher in the upper extremities and it's lower in the lower extremities distal to the defect. Then what kind of heart sound is auscultated for patent ductus arteriosus? Remember, that's that continuous machinery-like murmur. So postoperative care, after this client has had heart surgery, we need to report signs of bleeding like increased chest tube output. So signs of that are any kind of output greater than 3 mLs per kilogram per hour for 3 hours or greater than or equal to 5 to 10 mLs per kilogram for 1 hour. Next, we monitor for decreased cardiac output, like decreased blood pressure and decreased urine output. We also need to look for infection, like we do with any postoperative client, signs like edema or redness. Lastly, we need to keep that incision clean and dry to prevent any kind of infection. No tub baths for the first 3 days postoperatively. For our last NCLEX quick check, what should the nurse do if a client postoperative heart surgery has decreased urine output? Well, that could indicate decreased cardiac output, so we need to notify that healthcare provider right away. What should the nurse teach caregivers to do to prevent infection postoperatively? Well, we keep that incision clean and dry. No tub baths for 3 days postoperatively. Now you can master congenital heart defects on the NCLEX. Imagine secretions so thick and so sticky that they're almost like honey. Now imagine your clients trying to breathe through those honey-thick secretions, lining their lungs. Hi, I'm Krista, and today we're talking about the slow, sticky secretions of cystic fibrosis. So what is cystic fibrosis? Well, it's a progressive, incurable genetic disorder that significantly affects the respiratory and GI systems and decreases overall life expectancy. This is an autosomal recessive condition, meaning you need one gene from each parent in order to get this condition. So essentially, this is a dysfunctional exocrine gland. Specifically, it's the CFTR channel that transports chlorine and water on this exocrine gland, like in the respiratory tract. So in a normal airway, we'll see that chloride and water can freely move outside of the cell and thin those respiratory secretions. But in a dysfunctional CFTR membrane, that chloride and water cannot leave the cell, and therefore those respiratory secretions become really thick and sticky. This leads to copious, thick, sticky mucus in multiple organ systems. That leads to organ obstruction, and it causes things like obstructive respiratory disease and GI obstruction. This is diagnosed through family history, genetic testing, and an elevated sweat chloride test. So those dysfunctional CFTR channels are also in the sweat glands, leading to super salty sweat, and that causes that elevated chloride test. When you think cystic fibrosis on your NCLEX, I want you to think slow, sticky secretions. So those slow, sticky secretions can affect multiple organ systems, including that respiratory tract. So it obstructs the bronchi and leads to air trapping and atelectasis, as well as because those secretions are sitting there, bacteria can grow super easily, so it leads to respiratory infections. Commonly, we will see frequent infections like bronchitis and pneumonia in these clients. Also, because those secretions are really thick and hard to clear, we'll see chronic coughing and wheezing because of that airway obstruction. Because this obstruction is chronic, it can lead to signs of chronic hypoxemia like barrel chest and fingernail clubbing. So those same slow sticky secretions can also affect the GI tract and the intestines, and that can lead to intestinal obstruction. So in the GI tract, in our newborns, we will see this as a failure to pass meconium, that first poop, and that is usually the first warning sign of cystic fibrosis. In our older kids, this will appear as intestinal obstruction. Then that same slow sticky secretions can obstruct the pancreas and cause pancreatic ducts to be full with secretions and to block the release of digestive enzymes. This leads to malabsorption of those fats, carbs, and proteins. So we will see these clients will have malnutrition and growth failure. Lastly, because they're not getting a breakdown of fat, the fat will stay in that stool. So it will appear bulky, frothy, foul-smelling, and called steatorrhea. We'll see other effects in other body systems, like that salty sweat from that defective CFTR channel. Often when the parents will kiss their child, they'll notice it's salty, and that's another early sign of cystic fibrosis. Then that same slow sticky secretions in other areas we'll see in the reproductive system. So it will make it hard for that sperm to meet that egg, and it can lead to infertility. This is our first quick check. Take a moment to answer. What kind of stool is seen in clients with cystic fibrosis? Well, remember those slow, sticky secretions in the GI tract. That leads to malabsorption of fat. That fat then stays in the stool and it becomes bulky, frothy, and foul-smelling and known as steatorrhea. Remember, this is the same reason we have obstruction within the intestines, and that causes that delayed passage of meconium, that first warning sign of cystic fibrosis. In order to address all the problems caused by those slow, sticky secretions, our nursing care needs to focus on respiratory support, GI support, and psychosocial support. We prioritize that respiratory support because we don't want those thick secretions hanging out in that airway and causing an infection like pneumonia. We need to think about how to get those secretions out, like getting honey out of a jar. So we need to think about how to thin those secretions and mobilize them so the client can cough them up and out of that airway. In order to mobilize these secretions, we give inhaled medications like bronchodilators like albuterol and mucolytics like hypertonic saline. And remember, with hypertonic saline, that water follows salt. So that water will be drawn into those respiratory secretions so that they're thinned and more easily coughed up by the client. But when the NCLEX asks you which to give first, what do? We give that bronchodilator first. Why? Because it opens up that airway so that when we do give the mucolytic, that passageway is clear for the client to cough it all up. Then we perform daily airway clearance therapies, or ACTs. These are things like chest physiotherapy. That is when the nurse or respiratory therapist uses cupped hands to vibrate the chest wall and percuss it so that we loosen those secretions. This can also be done by a high-frequency chest compression vest like we see here that delivers the same vibrations to the chest wall. Then we can also see postural drainage. That is when we turn the client and elevate them in certain positions to allow gravity to get those secretions out of that airway. There's also positive expiratory pressure devices or PEP devices like this flutter valve here. This is something that the client blows into to create back pressure into the lungs that loosens the secretions. And it looks and sounds like this. Lastly, we'll see huff coughing, which is similar to positive expiratory pressure, and it creates that same pressure to help loosen that mucus. This is also done with our COPD clients. Another timing consideration that you need to know for the NCLEX is that we want to avoid performing these ACTs immediately before or after meals. Well, this seems obvious because banging on them or causing them to be elevated or turned in weird positions can cause nausea and therefore vomiting. So we want to avoid doing it around mealtime. So remember the order of these interventions. We give those bronchodilators first to open that airway and make that passageway really clear. Then we give mucolytics to draw water towards them to thin them out. Lastly, we perform those ACTs to help loosen and mobilize that mucus so the client can just cough them up and out. Those slow, sticky secretions can breed that bacteria that leads to those nasty respiratory infections. So to prevent infection, we need to encourage immunizations and hand hygiene. Clients with cystic fibrosis often have their respiratory tract already colonized by super drug-resistant bacteria and viruses, so they need to avoid close contact with other hospitalized CF clients because they can more easily spread those serious respiratory infections to each other. We need to immediately notify that healthcare provider for signs including respiratory infection that can be seen with subtle signs like decreased activity and decreased appetite, and pneumothorax, because long-term lung damage can cause blebs on those lungs, and if those blebs pop, it can lead to a collapsed lung or pneumothorax. So our next quick check, take a moment to answer. What should be done first? Give the client a bronchodilator or perform airway clearance therapy? We always do the bronchodilator first because it opens that airway to make way for those secretions to be coughed up. Then what subtle signs can indicate a respiratory infection in these clients? Well, those are subtle signs like decreased activity and appetite. So remember, those slow, sticky secretions cause that obstruction and decreased nutrient absorption in the GI tract. So we need to support nutrition. We need to promote high protein, high calorie, and unrestricted fat diets. This is to offset that malabsorption and because they have increased metabolic demand, because they have those respiratory secretions in the airway that cause increased work of breathing. We encourage increased salt intake and increased fluids during hot weather and exercise, like during physical education class in school. This is because of that defective CFTR channel that causes them to lose excess salt through that sweat. Because those pancreatic enzymes were blocked from those secretions, we need to replace that lipase, amylase, and protease to break down those fats, carbs, and proteins. So we give pancreatic enzyme replacement therapy, or PERT, which is these enzymes in a capsule form. And important on your NCLEX, give them within 30 minutes of eating. This is because this is around when they're normally released in the body. So as a nurse, we want to deliver these with a meal tray and have them take it with their first few bites of food. We do not crush or chew these capsules because it can destroy the enteric coating and decrease their effectiveness. We give those fat-soluble vitamins like A, D, E, and K because they have that decreased fat absorption, so we need to supplement with extra amounts of these. For other GI support, we monitor for those nasty complications from those slow, sticky secretions. We need to immediately notify the healthcare provider for signs of GI complications like intestinal obstruction that can be seen with abdominal pain or distension. Remember, those slow, sticky secretions in the pancreas can build up and cause pancreatic damage, and those can damage the cells that produce insulin, therefore leading to diabetes mellitus. Cystic fibrosis is an incurable and progressive illness that can cause stress and can disrupt normal childhood development. So we need to provide psychosocial support. We do this by connecting them with community resources like the Cystic Fibrosis Foundation that provide emotional and financial support. As nurses, we want to encourage physical activities like sports as tolerated. Not only does this improve lung function, but it helps support normal childhood development and allows for socialization. We want to address fertility and childbearing concerns because remember, this can cause infertility. For our last quick check, take a moment to answer. What diet and vitamins are best for cystic fibrosis? Well, remember, they have that increased metabolic demand and that malabsorption. So we want to give high calorie, high protein diets with vitamins A, D, E, K, those fat soluble vitamins. We give extra to make sure that they have enough. Which medication is taken within 30 minutes of eating? Well, remember, they're having that malabsorption, so we need to replace those digestive enzymes that they're not getting, that lipase, amylase, and protease, so we give that pancreatic enzyme replacement therapy around meals to maximize absorption. Then what kinds of activities should the nurse encourage for clients with CF? Remember, we need to encourage physical activity as tolerated. That helps improve lung function, it supports normal childhood development, and it allows for socialization. Now you've mastered cystic fibrosis for that NCLEX.